This is Rocky Snyder. At the tone, leave your name and message and I'll get back to you.
The reason of this call is to inform you that IRS is filing a lawsuit on your name because you had tried to do a fraud with the IRS Internal Revenue Service, and we are taking a legal action.
In today's episode, I get to chat with a friend and colleague, physical therapist Abby Linford.
So on this episode of the RockFit Files, I'm inviting a friend of mine who I haven't seen in several years now, Abby Linford. She is a physical therapist based out of, right now, Boise, Idaho, at a rehabilitation hospital where they focus on a lot of neurological issues, whether it's stroke victims recovering or people with MS, Parkinson's, total traumatic brain injuries or whatever the case. We're going to delve into a little bit of that, but I also want to kind of pick apart the world of physical therapy. So Abby, thanks for coming and joining me.
Thanks for having me, Rocky.
How long have you been a PT now? It's been several years.
I graduated in 2014.
2014, 6 years strong. That's nice. And is it everything you expected it to be and more?
It is so much more than I expected it to be, and so many things that I never knew it was.
So give me an idea. What do you mean? What was it that what has exceeded your expectations?
The relationships that we develop with our patients, particularly where I'm at, where I get to spend long bouts of care with people. So there's patients that I've had for 5 years since I've been at the rehab hospital that keep coming back for bouts of therapy because they have a progressive disease or something where we want to maintain their fitness.
Now that's not common. I mean, the typical person that sees a physical therapist usually has some musculoskeletal joint issues or something, or recovering from a surgery. They're allowed so many visits based on their insurance coverage or their financial well-being and how many they can afford out of pocket. But typically you're only allowed a certain amount of visits. This is kind of unique. You see people and patients, you've been seeing them for years. That's remarkable. Is that kind of common with the field of physical therapy that you're in?
I think this is the secret world of physical therapy I didn't know about, where I thought I was going to work with athletes and travel the country and work on orthopedic injuries, and that is not at all where my interest fell.
Isn't that amazing, that romantic idea of working with the Olympians, the top-notch professional athletes? I mean, everyone is a trainer and some type of athletic trainer, strength coach, physical therapist. It's like, oh yeah, that's what I want to do. But then you start getting into the nitty-gritty and you actually see how certain things can really create long-lasting change in a person's life. And it could be anybody. And I think you're right. That's kind of like the power of what we do. You really see that, no, I don't have to chase the millionaires or billionaires or whatever. The people that are right in our own neighborhood are the ones that need the help. I mean, that's what you're getting at, right?
Yeah, and how for me, it was more gratifying to work with people who were walking for the first time in several years or just being able to maintain their independence and stay in their home. That's more gratifying to me than working with somebody who can pitch again because their shoulder injury is healed, which tons of respect to the orthopedic therapists out there. I know some amazing ones, but that was just not what fit for me. Mine was the longer bouts of care where I'm really seeing people meet their goals, their functional goals, rather than more activity goals.
Give me one story that comes to mind when you think of, oh my gosh, this is the stuff that makes me want to wake up in the morning and go to work.
Oh, there's so many. I've worked with a patient who hadn't walked in 14 years, and we jumped in the pool first and said, let's just start moving and seeing what your body wants to do, like what's positive here. And little by little, we just kept going, and then on land, and then she was walking with a walker, not totally independently, but just such a dramatic change, and how much quality of life that brought her, and confidence to be on her feet, and her relationship with her husband improved. I mean, just it brought life back to her that she had lost.
Did somebody say that she'll never walk again, like in the
Oh,
early
just
years?
all the
I mean,
time.
she
All the
got it
time.
all the time. So people
Oh.
were creating this reality for her that did she continue to believe it? I mean, what was that point where, I mean, 14 years of hearing that over and over, but there must have been something, somebody said something, or she saw something. What was it that made her decide, you know, I'm going to try and change that?
I presented walking, and I just told her that's what we were going to do.
That's
awesome.
Awesome.
Just watching her move, and just knowing that she had more in her than she knew. And I'm kind of a shoot for the moon, and if we end up in the stars, we did something right, you know? So
Right on. Yeah, I love that. I love the overwhelming awe that can come across a person's face when they suddenly realize that the reality that they were believing does not have to exist, that they can actually go and do something that they thought was nearly impossible or beyond their means. I had a woman in here not too long ago who truly believed that she was going to live with back pain for the rest of her life. We spent 45 minutes just kind of watching how she moves, just like you were saying, just watching what her hips were doing and realizing they weren't doing what they should. And as soon as we started getting them to move the way they should, suddenly things changed, and she started crying. She was just, I can't believe it, that the pain that I've been living with for so long is not there right now. And it wasn't the back. It wasn't the back at all. The back was just like the megaphone of her body screaming out for somebody to pay attention to what's going on. And I guess that's if there is a little, my little kind of dig at physical therapy is that the outdated way in which many physical therapists are still presenting an approach to their clients, meaning the symptom-based approach. I've got back problems, so we have to look exclusively at the back. It may not, it's got to come from there. They don't consider, well, maybe it's related to that inversion sprain you had on that ankle 2 years ago that developed a new movement pattern that eventually got that back to wear down. But you're not that way. You don't have that symptom-based approach. In fact, it's really quite refreshing just to hear that story of breaking away from what everybody else was thinking about this one patient of yours and saying, okay, we're going to try and do something that you haven't done in a while, and we'll see where that goes. So what got you into that field, though? I mean, the last time we were talking, honestly, I think you were just finishing physical therapy school and you were on your way out of town. And
gosh.
Yeah, what brought you there?
Hats off to the program I went to, Samuel Merritt University in Oakland, California. I honestly think that they're providing a pretty stellar education, at least when I was there. You know, instructors saying things like, don't chase pain, you know, which feeds into what you were saying, is, you know, identify the movement dysfunction, identify what's moving too much, what's not moving enough, what's could be pathological, and treating that first and seeing, does the pain go away, you know. And I was listening to a brilliant podcast by this gentleman named Rocky, and he was talking about oh man, you're saying a lot of brilliant things. I was going back listening through your podcasts, and just putting your hands on someone, right? Mm-hmm. Just that tactile input can change the sensory output, or, you know, what your brain's receiving. So just putting in that positive touch, and, you know, we see that over and over again. So if we say, you know, I'm going to treat your back pain, I'm just going to do some manual therapy here, some touch here, and they leave going, great, I feel so much better. But did we really change anything, or did we just put in the tactile input to feel good for a day or two? So, I mean, I agree with you, you know, treat the dysfunction and find out what's not moving well, and then reevaluate and see where you're at once things are moving more adequately.
Yeah, because really, many times all we're talking about are almost like the distance of microns or millimeters. It's not really that you're trying to change a person in their structure or the way the joints move enormously. It's just enough to get them out of that place that they've been in and repeating these patterns of movement that have been just continually adding more compensation to their motion. You said something about evidence-based, and I love evidence-based approaches, with the exception that it takes a long time to build up that evidence. Do you know? I mean,
Sure. Yeah.
if we're looking at research results, first, a subject matter had to emerge interesting enough for a researcher to grab onto it. So it's been something that's been going on for a while. And then once they do think of researching that topic, then it's going to take a while for the research to actually take place. And they extrapolate the summation of it. What were the results? And then to get it published. I mean, we're talking 10 to 15 years before that evidence that we're talking about actually makes it out to mainstream in the form of periodicals or internet reports or whatever. So I love the fact that you said some of your instructors took the experiences they had out in the field and brought it into their classroom, because now we're blending experiential and evidence-based approach together, which I think is a much more powerful way of doing things. I mean, look at what's coming out right now. What we're talking about breathing, how much more, there's going to be so much research coming out about breath work 10 years from now. And yet most of the people are doing all of like the Posture Restoration Institute or the DNS stuff. You know, we're working on proper diaphragmatic rhythm and breathing and so on. That's the people out in the field like yourself are the ones that are leading the charge. So what's the big thing that you're doing with the majority of your patients? We're talking first, let's list the types of people that are coming in, or not the types, because everyone's different, but what are the common issues that you're having to address with the people that come in and see you?
Typically balance will land you in PT pretty quick. So any balance deficits, gait abnormalities, which could be anything from drop foot to scissoring gait patterns, ataxic gait patterns, antalgic. It could be anything there. Weakness, we see, paraplegia, we see, paralysis, anything that is getting in the way of functional mobility. So it could be range of motion deficits as well, but to get into our clinic, usually there needs to be a neurological component of it, because we also have the other sides of it. So we have the orthopedic, vestibular therapists, so many other areas that I never knew existed. You know, wound care is under the scope of practice of physical therapy, which I was very unhappy to find out.
Interesting.
Yeah. So,
wound care, really?
Wound care. Mm-hmm.
In terms of like burn victims, or in terms of post-surgical scarring, what are we talking about?
Like diabetic ulcers, non-healing wounds, so not just rehabilitation from, say, a skin graft, but actual treating the wound with hyperbarics, electric stimulation, debridement. Not an area of interest for myself.
Interesting, yeah. I wouldn't think that was categorized with the types of neurological patients that you would see. Yeah, interesting. I could see, though, and I have seen it, how scarring and wounds will greatly affect a person's ability to move, even years after those wounds have healed. The scarring, whether it's the piezoelectricity, the current that goes across the flesh or skin has been disrupted, and so the brain is not really getting an understanding of what's there. So the movements are changed, but as soon as you stimulate a scar, then range of motion can improve and so on. It's really kind of fascinating stuff. But when we're talking about ulcers and things, that's very interesting. Well, back to the balance though, I'm kind of curious, you know, we've got three elements that really help our balance, or they help to basically control, govern. And there's vision being the first one. 90% of our balance is really through our visual field. And then we've got, of course, our proprioceptors, all the mechanoreceptors of tell us where our body is through space, and our skin and joint capsules, tendons, muscles, fascia, so on. And then we've got, like you were mentioning, the vestibular. When you come into your balance approach with your clients, do you address all three, or is there one, is it just vestibular that you're dealing with? What's your typical approach? I'm really curious.
Yeah, so part of our job is to suss out which area is affected. There's an exam called the Foam and Dome test, where you can isolate each part of those three pieces of balance. Where we look at it first, usually, or where I look at it first, is functional. Like, first, I've just got to make sure we're keeping you off the floor. So look at some compensatory strategies and safety. And like you mentioned, that sensory input, the mechanoreceptors. So if we get somebody on a walker, now instead of 2 points of sensory feedback, they're getting 4 points of sensory feedback, right? And then something that I think a lot of us don't think about is, if I put my hand on someone, I just added another area of sensory feedback for balance. So in my testing, I need to be really aware of that too, that I'm not adding in some factors there. So absolutely looking at the deficits is, and if it is a vestibular issue, and like BPPV, benign paroxysmal positional vertigo,
yeah,
that is purely vestibular. And so we typically send those folks over to the Hearing and Balance Center, where there's dedicated vestibular PTs who will take them through the movements, like Epley maneuver, and see if they can reset those crystals so that the BPPV clears up. And then we look again, is there another balance issue? You know, if we get vestibular system figured out, then is it mechanoreceptors, proprioception? Is it the sensory feedback, or is it just weakness issues, or is it visual? And something that we see in brain injuries often is a change in your orientation to midline that occurs in the brain. So after somebody has a stroke, this doesn't feel like upright anymore. This feels like upright.
And is that because of the excitation of one hemisphere more to the other, and it's drawing more stimuli into that region? So that midline within the brain, within the cerebellum, we've got more inhibition on one side, more facilitation or excitation on the other, and it kind of draws the midline or the perceived midline over? Do you know? I'm just kind of curious.
That's an interesting point. I don't actually know, and I could make something up, but I like your...
Oh, heck, let's do that.
Yeah, let's better. Yeah, I don't know exactly. But so it can create a pushing behavior where the individual is so convinced that they're going to fall to, into danger space, they will push to get back to where they feel upright, which is often going to push them into a fall. That's often the side that's been more affected by the brain injury. And so they'll often push themselves to very dangerous space.
Gotcha.
So we try to correct that with, like you're talking about, the visual input. So if you get somebody next to a wall and you convince them that wall is upright, if you're coming away from that wall, even though it feels right, you know that it's not, because your vision's telling you where upright is.
Wild. Now, you also work with people living with Parkinson's disease, and there is this approach that I have come to know, though you need to be a physical therapist or occupational therapist in order to go get certified or licensed. And they just, although I've talked to them at length, and they're still saying, no, you can't do it because you're not a PT. However, we are looking at expanding our approach to include strength coaches like yourself, and we'll give you a call when we do that. But that's the LSVT, which is the Lee Silverman voice training. And they've done a lot of research out of Duke University in North Carolina there. But the LSVT, are those big movements things that you do with your patients? Because I imagine there's some carryover there.
So we have two therapists on our staff that are certified in the Big and Loud program. Well, we have the PTs who are certified in the Big program, and our speech therapists are certified in the Loud program, which is really fun when you're walking down the hall and someone's shouting out of their room, "I want a sandwich." But man, it works. It's awesome. It's such a good program, and I absolutely think that other disciplines should be involved in that, because it's a great way to increase the movements. You see the bradykinesia, smaller movements with folks with Parkinson's as it becomes more advanced.
Yes, the stiffening, the freezing, the vocal inhibitions. We were participating with one of these classes at the local hospital in Santa Cruz, and without fail, every time we're in the room, like, we're going super slow, we're going super fast, we're going super loud, we're whispering, and we're changing things and making novelty, because the cerebellum loves novelty, and it's going to get the dopamine going. So we're changing it up. Okay, every time you got to say this with the name of a dog, or you got to yell out your favorite movie. And without a doubt, the hand therapist right down the hallway would just kind of stomp over and close the storm doors, because we were just having too much fun, and they didn't want to participate. But it was great. It's so nice to actually make some amazing changes in people's lives, rather than simply carrying heavy weights over to somebody where they can count to 10 and put them back on the rack. I mean, it's just, what you're doing is just fantastic. Where do you see this going? What are the holes in the system? If I could just, with your, I'll say, young eyes, you haven't been institutionalized, you haven't been there for decades upon decades, to where you have just become kind of formalized into the same rote day after day. You still have bright eyes and are learning outside of what you're doing at work. So what are the things that you feel like you can still bring into such programs, or what's missing?
One of the biggest things missing is the preventative. Why are we not seeing PTs once or twice a year like the dentist, everybody, and saying, hey, you're getting into youth soccer this year, but you're also growing. Let's look at some of the areas that, we need to really focus on strengthening. Let's prevent all these ACL repairs in young soccer players. So many of the injuries just don't need to happen. That's the orthopedic side. Mm-hmm. And then, most physical therapists, at least all the physical therapists graduating now, are doctorate level education. We spend a bigger chunk of time with people. We're trained to identify things that don't look right if they're out of our scope. So why aren't we the ones going in and saying, you're, not answering things as quickly as you were last year. What's going on there? And checking blood pressure on people yearly. I can't tell you how many people I've had that have had a stroke that had uncontrolled blood pressure and didn't know it. They skipped the doctor for a few years. Let's get ahead of this with prevention, and so many things.
That's going to involve a front end cost. That's the problem, I think. And that's what we're finding with our relationship with some of the hospital in town, where we're trying to accumulate statistics with the seniors and the elderly that we train, to show that a program of preventative maintenance and improvement on their health and wellness and their fitness will reduce doctor visits, reduce medication, reduce repeat hospitalization care, which would incredibly reduce the costs that are incurred by the hospitals. And I gotta say that many of the financial officers in the healthcare system are not really willing to invest in such things. Unfortunately, it doesn't seem to be, at least. But there is hope. Actually, I get to present to the Medical Fitness Association and their international conference coming up this fall. And there's several speakers that are talking about this. So there's rumination, which is a really encouraging thing, that people are really starting to say, okay, what if we put a little bit of cost up front? How will that benefit us in the long run? And you guys would be on the battle lines right there, the front edge of this whole thing. And I got to put on a rant right now too, and you may support me on this, or you may say, actually, in Boise, that's not so. But I've got a rant on my colleagues, the personal trainers, the fitness professionals, for not connecting with the medical profession. These are the people that are the ones also on ground zero, that are seeing the people that could easily communicate with the medical profession, with the athletic trainers, the physical therapists, the orthopedists, the primary care providers, and start to create a team approach. And yet, for many trainers, they think they're the end all be all, that I can actually help you lose weight, reduce your diabetes, increase your testosterone or estrogen levels, or help you recover from anything you want, because, you know, I'm the cat's meow, so to speak. But there needs to be something within our field, the fitness professionals, going, you know what, we are not isolated here. We're not all that and more. We need to create a network amongst people like yourself. So with that, go ahead and tell me that your hospital has a whole bunch of strength conditioning specialists around you, and that you work in a network outside of there as well, right? No? Yeah?
I see it a little bit. I don't see it enough.
All right. Okay. So you talk with personal trainers?
I don't, mostly because my clientele don't often have a personal trainer.
Okay.
But I would love to see, and one of the frustrations and one of the gaps is when your insurance runs out, or when I can no longer justify skilled physical therapy, who do I send you to? And I've been building my own network. I have a couple of yoga practitioners in town that have expressed an interest in working with people with neurological conditions. It also takes some bravery and comfort on the side of the trainer or the yoga practitioner or whoever, to say, teach me. You know, this isn't my area. And that's, you know, what you were saying with these egos. There's no room for egos in healthcare, in my opinion, and that it's rampant. I see it in my own profession. I see it in athletic trainers, personal trainers, chiropractors. I see it all over the place, that we're afraid to say, let me help you find somebody that's going to meet that need for you. It's not me. Like, why are we so afraid to do that? I would so much rather any professional refer me out if it's beyond their scope, and it makes me respect them more and want to refer to them. So I would love to see that we get rid of the egos, and that athletic trainers and physical therapists and personal trainers stop the turf war of that's mine, I can do that, I can do that better, or I know more, and instead say, what does this individual need, and who's the most optimal person to give that to them? So I want a huge network of people that I can communicate with and say, hey, I've got this person with multiple sclerosis, and they've got this goal of, you know, hiking Table Rock this year, and who's going to get them there? It's not going to be me, because we've surpassed a functional goal. You know, you're walking, you're hiking, super. Now I've got to get you to somebody who's going to train you. And I want to communicate with that person so that I can help meet the goal on the other side. So I would love to see better integration of all these professions rather than a turf war.
All right. So if you're just tuning in right now, and somehow you hit the fast forward over the introduction or whatever, I'm talking with friend, colleague, physical therapist, Abby Linford. based out of Boise, Idaho, currently working, and she works with a lot of people that have neurological deficits, challenges, disorders, and so on. With your work, I imagine that you also find people who come with you and relinquish their own care, their own reliance or responsibility for their own well-being. They're coming to you because you're going to fix them, rather than being a guide that is going to lead them into fixing themselves with the help of whatever tools you have. Do you find that that is a regular occurrence with you? And if so, how do you try and turn that kind of mindset around to let them know that, no, I'm here to help you. I'm not here to fix you, because that's what you're going to do.
The learned helplessness is huge, especially because the weight of a diagnosis on how someone views themselves can be so detrimental. Not all healthcare professionals take the time to educate someone on what the diagnosis means, or they're not addressing it properly, and they're setting limitations, saying, you know, you've had a stroke, your balance is off, you need this wheelchair, you're not going to walk again for at least a year. And you start setting those expectations and limitations on someone, goes right into the brain, and they're no longer believing in themselves. And they've been told they can't, not necessarily why. You know, is that going to cause me to have another stroke? Am I going to fall and hurt myself? Like, the fear factor there, and someone just gives up their, and this isn't all patients or clients, but it is common where people just give up sort of the onus of their own health and says, tell me what I can do safely. Just, you know, that's my wheelchair. Okay, I'll, you know, sorry. So that on the, you know, on the doctor's side, or whichever healthcare
It's got to be
professional
frustrating.
told them,
it's got to be completely frustrating.
Yeah. And like you said, you know, people getting told they're never going to walk again all the time. And, you know, then they tell me they go back into their doctor, and I'm all excited. I said, did you walk? And they say, yeah, I walked in and I sat down, and the doctor said, well, I didn't expect that you're going to be able to do that. It's like, let's build people up, you know?
Yeah. No kidding. And then the other question in my head is like, well, what else didn't you expect? What are the things that you have created for this person? You know, it's amazing how powerful words can be when they're received and not the way we intend them, or maybe they did intend them and just said, okay, hey, this is just how it's going to be based on the pages that I've studied in this book, whatever the case may be, not based on necessarily the experience of the person that's walking through the room. That's crazy. So when you're dealing with somebody, you mentioned somebody who's had a stroke. You know, I have read several articles on autism and how there are such amazing individuals who have a certain inhibition in one area of the brain where it's not as stimulated as certain other areas, and they make up for it by another area of the brain, another skill that develops to a heightened level. And I'm not necessarily talking like savants, but we could categorize it in that area. My question is when we have an area of the brain that is affected by a stroke or a traumatic brain injury, have you ever found clients who have suddenly acquired new talents, skills, abilities because of the neuroplasticity of the brain and kind of almost super compensating in other areas? I don't know if that ever happens. I'm just kind of thinking about it. I'm like, wow, I wonder if that has ever occurred.
Not that I can think of.
I don't mean to put you on the spot.
No,
but I'm just kind of curious.
Not that I'm aware of.
Okay, so none of your patients they haven't taken up like a certain skill or a hobby or something like that, and suddenly they're running away with it.
No, but I would love to see that. And we're only scratching the surface on neuroplasticity. I mean, the fact that we're even talking about it and that it's becoming more common knowledge is proof that it's finally gaining the traction that it needs. But again, the information gap, it's something that we knew about, and now it's coming into mainstream, you know, that the people understand the plasticity of the brain, and that new pathways can be formed, new skills, you know, even just remapping the brain to regain function of a limb after that particular area of the brain that was doing the work has been damaged. So, you know, we're not only seeing like healing in the brain, but we're seeing plasticity of using other areas, you know, finding new landscape in the brain to make the pathways required to do that, have that function again.
Yeah, the brain science has advanced more in the last 5 years than the history of mankind, right? Of humankind. It's just, that's remarkable how much science has learned about the brain. Just it's amazing when you consider it. It's almost like when you look at the timeline of the entire Earth, and then you see where man came into play, and it's just, if you put it on an actual calendar of the year, we're like December 31st at 11:55 p.m. right? It's kind of like that with brain science too. It's like if you put it on the entire spectrum of the history of man, we're at New Year's Eve at a few minutes before the hour. That's how far we've gone. But the amount that we've learned is fantastic. So with your patients that are having, say, let's just continue with the stroke, because I'm interested in the approach, because I hear several different approaches with stroke victims or people that are living with the effects of a stroke. Some approaches will, of course, really work the affected side. Let's just say that left frontal cortex was the area that was damaged, blood flow, whatever happened there. And so the right side of my body is the affected side, right? Okay. Right. And so the approach that you would imagine is, okay, we're going to really try and stimulate the right side of the body to help feed this kind of connection there. But then what happens if I feed the same side? We call that ipsilateral, right? We feed the same kind of movements to the left side. I know that when I work my left side, it actually sends neural stimuli over to my right to create stability to help me with balance. You know, when I hold on to a weight on my left hand, the muscles on my right side have to engage so I don't topple over to my left. So when you're working with your patients, are you I won't say playing around, I'd rather use the word explore. Are you exploring different movements, and how do you assess and reassess the efficacy of the movements that you're providing
them? Yeah, you're talking my language right now. So after I graduated PT school, I actually had an opportunity to do the proprioceptive neuromuscular facilitation residency program at Kaiser Vallejo.
Nice.
And that's
do you want to just say what PNF is? Do you want to tell them what PNF is first? For anybody listening, they're going, oh, those are 3 big words. And I'm just this muscle guy that I lift all weight all day long. I have no idea what you just said. That's me, by the way. Mm-hmm. Yeah, come on, throw it out there. Give me your layman's idea of what PNF is.
It's using those principles of neuroplasticity with how the body naturally works. So we know we work better in diagonals than we work in linear planes. So if I lift a bag of groceries with my right arm and I just pull it up with my bicep, I'm going to be significantly weaker than if I come from the left side and I bring that bag across my body and I'm incorporating my core, my trunk muscles, my legs, everything we're so much stronger in diagonal patterns.
Yeah, the way I kind of think about it, we've got these X's on our body, right? We've got an X in the front and an X in the back. So my right shoulder comes and it connects to my left hip in the front as well as in the back, and then vice versa on the other side. So I have these paths of tissue, and we use these kind of proprioceptive neuromuscular facilitator, or PNF paths, to create movement. And we've been doing that for millions of years, rather than the bodybuilding or old-fashioned isolated approach that we'll find sometimes in the physical therapy units too, where we're just isolating a muscle and not actually integrating movement. So you're really talking about an integrative sort of approach to movement to stimulate different areas of the brain.
Yes, and then the facilitation piece where we get in there with hands or setup, or how can we facilitate the best outcome we can. So when you're talking about, what about the left side there, we want to bring that in. So the PNF approach is looking at what's positive, what's working. So when you do movement analysis on someone, I'm not just picking out what's not working, I'm also looking at what is. Because we're going to use all of those strengths to facilitate what's not working as well.
Yes.
So
in
absolutely.
my world, I look at gait, and it's probably because I've been studying it for several years now, but it is the one movement that all humans, for the most part, the majority of people can perform or should perform, and we've been doing it for over 1 million years. And so over that time, a neurological connection between the joints, the soft tissue, everything is set up to do these repetitive gait patterns over and over. So if I've got an area of the body, we'll say the right shoulder, that isn't moving well in a forward kind of swinging action known as shoulder flexion, then I might say, well, what occurs at the same time when shoulder flexion occurs when a person's walking? Can I stimulate those other movements so I can feed this kind of neurological chain reaction and see what happens to the shoulder? So we start doing all these gait patterns, which is the thing I love about the big program, going back earlier conversation here with the LSVT big, because if you really look at those patterns of movement in their big exercises, you're going to find that they are actually derived or exaggerations of the gait cycle, which is phenomenal. And we see this in yoga, we see it in Tai Chi. We've seen it for years and years. We just are now putting the pieces together in our Western world, It's kind of wild.
And that's a method of treating, is like you said, exaggerating those movements, not just with the big program with people who have Parkinson's, but my patients with multiple sclerosis, even just patients who have become deconditioned, that they're often the trunk becomes so much more rigid because they're moving more cautiously, taking smaller steps, moving at a slower pace. When we slow down our pace, our arm swing goes away. Well, when that arm swing goes away, now normal rotation through the spine goes away. And then what's that doing in the hips? And then all the way down the chain. So,
and then you start throwing weight training in the traditional sense into that, thinking that, okay, we're going to build up your strength and do these weight training exercises that we'll find in the gym, selectorized machines, circuit machines, or just your traditional stuff. But what are they trying to do? They're promoting more trunk stability and stiffness, So
right.
It's very interesting.
Yeah. And a lot of machines are one size fits no one.
Yes.
So you're isolating a movement, you're isolating leg press or something like that. But now you don't get that normal movement through the back. And so is that really beneficial, or are we just limiting strengthening? And I would say that we're increasing stiffness with that kind of training.
Exactly.
And it's not a functional strength.
No.
Which is why I loved working out with you so many years ago, is, it really set into my mind that function is what matters, not your beach six-pack, and bulging biceps. But if we can't move and have strength in function, then what good is it?
During my mating years, the rituals of my 20s, there was a purpose for those biceps and six-packs. But now that I have offspring and so on, I've got to think of a different different way of getting my body to stay the way it is, or improve the longevity. Now, one other thing, I know we're kind of coming up on the clock here, but I want to just ask you about neuropathy and drop foot, where people are having a limited sensation in their extremities. So peripheral neuropathy, your peripheral nerves are basically diminishing, whether it's like necrosis, the death of cells, or if it's just diminished stimuli. Whatever it is, we can argue those points later, but let's just talk in the lower extremities, not so much the hands, but the feet. We have this mat here developed by a podiatrist out of New York. Currently, actually, she's in Arizona, Dr. Emily Splichal, and she developed this mat that has all these diamond-shaped bumps on them, and it's called the Nabozo Mat. Are you familiar with it?
Yeah, we have a couple of the shoe inserts that that we've been trialing with patients, and some people just love it.
Don't they?
Yeah.
Honestly,
bringing the attention to the feet more. I know a good friend of mine who has MS bought a pair the first time she tried them in the clinic. She was like, "Well, these are amazing. I now can communicate better with my feet because it's adding that." It's strengthening the sensory input that the brain's receiving from the foot. So now foot placement's improving and balance improved. And yeah, I think it's really neat.
Yeah, so then considering that, stimulating the soles of the feet with a mat of that sort, and we have the same effect here with the people with MS, Parkinson's, and neuropathy that work out in our facility. As soon as they kick off their shoes and stand on that mat, they don't want to go anywhere but that mat. They're like, I want the whole facility to have flooring just like this so I can walk everywhere because this is amazing. I don't even know how much that would cost, but it's cost prohibitive as far as I'm concerned. But here's the thing that what's that?
Do you have people lay on it ever?
Yes, yeah.
Because I didn't know there was a whole mat. I would love to get people laying on it.
It's the size of a yoga mat. And actually they have different sizes. But you get them laying down on it, you get their hands on it, you get them in a quadruped, doing some yogic poses, anything like that's phenomenal. Not only the soles, but you've got the Nabozo Mat. And so this is not a paid promotional advertisement, by the way. I don't get anything from it. So I just want to put that as a disclaimer right now. But here's where I'm going with this is, though, if we can stimulate the base of the foot and have that response with little diamond hard rubber shaped mats or insoles, what's to say we can't do a little bit more? There's rock mats, of course, where people are starting to get really popular with that, where you're walking on these river rocks and small stones. But I guess my question is, can we get a area of turf, like actual real grass, sand, maybe a pebbly kind of soft pebble plot that we can put people on, have them just walk in nature once again, and just see does that have the same effect? I'm just curious, You're out in the great outdoors in Boise, Idaho, so I'm giving you an idea to run with. And in 10 years, when you're the multimillionaire who has all these products developed, you're going to look back and go, yeah, I could probably send him something free. That's where I'm going with that right there.
I'll remember the little people, Rocky.
Oh, that's so good. Yeah, and I'm glad you say little people, because we don't appreciate being called dwarfs or hobbits, but it's all right. Well, hobbits are actually cool. Anyway.
Let me rephrase. I will remember the people that got me to where I am.
Ooh, there you go. Oh, Abby, this is so good. Now, if in the event that I know there's probably going to be at least thousands of people in the Boise area listening to this podcast in the very near future. So all your patients, clients, and then all their family and people that don't even know you, because I'm big in Boise. I don't know if you know that. I'm huge in Boise.
Well, I promoted you.
Yeah, well, thank you very much. If we want to know more about the approach that you're taking to the rehabilitation hospital, do you mind saying the name of the rehabilitation hospital? I think we've done a good job with our conversation where they're not going to go, oh, take that off the air.
Let me think back. Nope, I'm pretty sure we're clear. Okay. I work at St. Luke's Rehabilitation Hospital. It was formerly the Elks Rehabilitation Hospital. It's been in Boise for decades. They started with the polio epidemic, and have just been an amazing facility. And that's why I work there now. It's because I did my observation hours there before PT school, and I recognized what a special place it was. And I vowed to show up until they started paying me.
That's awesome.
So
go ahead.
I was able to do my clinical rotations with them, a couple of them, and I just, it's such an amazing group. When you have really dedicated therapists, you feed each other. And I think that's the reason it's a special place, is because nobody gets to be burnt out. You know, it's a really passionate place. And I think that, what I recommend to PT students graduating is you have to have good mentorship in, at the very least, your first job. Because if you go into a clinic with 1 or 2 therapists, you can't just absorb and grow as a therapist. And that's why I'm at where I'm at.
Right on. Okay, now this is completely non sequitur, but you lived in Santa Cruz for a little while. Did you ever surf while you were here? I gotta ask. I think you did once
I
or
tried
twice,
it a
didn't you?
couple times. Turns out
Okay.
I'm afraid of sharks, so I just laid on my board and bobbed around.
Well, you'll be happy to know that there are no sharks in Boise, as far as I know, and maybe the aquarium has them, but out in the real world, no. But there is a wave that you can surf in Boise, and I'm wondering, you know, if the chance comes that I'm in Boise, I'm taking my surfboard with me, because the river right there, the town of Boise actually created a standing wave that you can surf on a regular basis. They actually created it in one of their little riverways. Do you know where I'm talking about?
I do. I know exactly what you're talking about. I'll take you there.
Oh, please. Okay. That's it. That's the cost of appearing on the show, is a little surf trip to Boise. There you go. Abby, this has been a joy. Thanks for taking some time and chatting with me about all things just beautiful in your life. I really appreciate it.